Hi, my name is Stephanie Twist. I'm here with Dr. Elise Thacker and Dr. Baha Moshiri. Today we're going to be talking about the overlap of functional dyspepsia and gastroparesis. We will also be talking about behavioral medicine and IBS. And so we're going to go ahead and get started with Dr. Baha Moshiri first. Please remember, we want to be able to answer all of your questions at the end of the presentations. But remember, we cannot answer any personal medical questions, but we will try to address all of them as much as possible. So I'm going to go ahead and hand this over to Dr. Moshiri, and thank you so much.
Thank you, Stephanie. So thank you to the American Neuromotility and Gastroenterology Society for letting us do this presentation for you guys. I'm going to talk about the workup of patients who have nausea, vomiting, and we will definitely discuss both functional dyspepsia and gastroparesis that oftentimes are difficult to differentiate for GI physicians as well as for the patients to describe. These are my disclosures listed here. We know that nausea and vomiting are the leading cause of GI symptoms in outpatient visits. They're actually number 4 and 5 that are listed, and in clinic, it's the number 10 diagnosis that doctors make. Referrals for gastroparesis in the United States have actually been on the rise. We don't know if some of that is due to cannabinoid-induced hyperemesis, the increased incidence of cyclic vomiting syndrome, and other disorders that may be confused with gastroparesis. But for example, in our hospital, it's number 12 listed with 2,900 patients that are referred to us. Functional dyspepsia is much more common than gastroparesis, and the costs and hospitalizations for both of these disorders are going up. So this is a study that was done by Liu in children and looking at their hospitalization costs for gastroparesis, and this has been increasing at a rate of 3.4 million per year in children from 2004 to 2013. Vomiting absolutely leads to impaired physical and mental health. This questionnaire that was done by the IFFGD was a gastroparesis survey that was distributed to 2,249 adult patients, of which 1,423 had gastroparesis. They reported a mean duration of disease of 9 years and an onset of 5 years. And when they filled out their typical questionnaires that we give these patients, called the PAGI-SIM and the SF-36, which is a quality of life questionnaire, we found that these symptoms negatively correlate with patients' mental and physical health, and that 60% in the survey were either dissatisfied or somewhat dissatisfied with the treatments, meaning only 40% of patients were happy with their treatments. BMI and age actually did not correlate with either impairment in physical or mental health. We also know that the severity of gastroparesis symptoms absolutely correlates with higher disability scores, and we actually interestingly found this back in 2010 in both caregivers and also patients with gastroparesis. The symptoms that patients present to us with are nausea, which is an unpleasant subjective sensation with an urge to vomit. Retching is this spasmodic, abortive respiratory movement with the glottis closing that is not really vomiting, but it's the patient initiates and is about to vomit. And then vomiting is partially voluntary act of forcefully expelling gastric or intestinal contents. It may be bile, it may be food, it could be any of those, but it is again a forceful act, which is very different than regurgitation, which oftentimes they can get confused with. Regurgitation is effortless reflux of gastric contents, whatever they may be, bile or not, into the esophagus. The Rome-4 has been very vital in differentiating patients and defining those patients that are really functional dyspepsia. And there are differences between that versus gastroparesis, which requires that patients have some kind of testing to prove that the patient does not have any mechanical obstruction and that the patient has a delayed gastric emptying, whatever transit study's done, and we'll talk about that later. Most of the time, we think of gastroparesis as a motility disorder, but that may not necessarily be the only case. There are sensory disturbances. Pain is reported in 89 to 90% of the patients who have gastroparesis, and the prevalence of gastroparesis is a lot lower than it is for functional dyspepsia, which has a sensory and motor disturbance as its cause, and the prevalence is about 20 to 40%. The Rome 4 criteria for functional dyspepsia are defined as such: one or more of the following: bothersome postprandial fullness, and this bothersome early satiation, epigastric pain, and then epigastric burning, and no structural disease. So that could include an upper endoscopy that explains the symptoms. These symptoms have to be experienced at least 3 days out of a week. And there are two groups of these patients. Some patients will report that they have meal-dependent postprandial pain, and others will just have the epigastric burning. So the area in the brain, the gut, and the spinal cord that controls nausea and vomiting is very intricate. And drugs and other things can affect these, such as diabetes, for example. The emetic center, which is the nausea center in the brain, is in the medulla, and it's in the dorsal portion of this area, which is also where the afferent neural pathways are, which we call the vagus nerve. We also have this area in the brain that's called the chemoreceptor trigger zone, and that's also located in the fourth ventricle of the brain, and it's another nausea center. And then there's sensory mechanisms in the actual stomach that also control nausea. So nausea can be experienced in any of these locations. And there's circuitry where most of these other drugs can work in, even, for example, histamine can work in many of these. Dopamine receptor antagonists can work directly in this nausea center in the brain. Serotonin and serotonin inhibitors, like the 5-HT3 inhibitors, such as ondansetron, work in these different areas. And then also cannabinoid, the CB1 receptor, is located in the dorsal vagal complex, and it has inhibitory effects on nausea. And there are others, such as substance P and neurokinin 1, that even have receptors in this area. So what are the other nausea vomiting syndromes that are defined by Rome 4? Because oftentimes when we see patients, these are other thoughts that we have in our mind in terms of differentiating patients correctly into these designations. Otherwise, the treatments will be somewhat different. So chronic nausea vomiting syndrome is very similar to patients with gastroparesis. These are bothersome nausea that occurs at least 1 day a week, and they may have 1 or 2 vomiting episodes. These are they cannot be self-induced vomiting. They cannot have rumination or eating disorders, so those have to be differentiated from this. And there's no other organic reason for these symptoms. You have cyclic vomiting syndrome, and this incidence is about 3 to 14% of adults with unexplained nausea vomiting. It was actually the pediatric folks that were more in tune with cyclic vomiting syndrome than in the adult world. And with this syndrome, there's at least discrete episodes in the prior year and then 2 episodes in the past 6 months that occur at least 1 week apart. There's complete absence of vomiting, usually between episodes, but sometimes mild symptoms may exist. And these are really stereotypical. So the difference is that the patients will report that usually it happens at the same time that it normally happens, and the duration tends to also be stereotypical. Most often, patients may have a family history of migraine headaches, and they may also report that they do take prolonged hot showers, which was something we formerly thought was reserved for the cannabinoid-induced hyperemesis patients. Cannabinoid hyperemesis syndrome was first described actually in 2004. It's also stereotypic vomiting that really resembles cyclic vomiting syndrome in terms of its onset, duration, and frequency. The presentation is usually after excessive cannabis use as defined by Rome criteria. And these patients also report taking excessive hot showers that kind of helps their symptoms. Rumination syndrome, we don't see as often as I think the pediatric colleagues, but it may be something that we've missed. It's a persistent recurrent regurgitation. So this isn't actually vomiting at all. The patient regurgitates recently ingested food into the mouth and then either spits it or swallows it back up. And this is not usually preceded by any kind of vomiting or retching. And this is effortless. It's not usually preceded by any nausea. And, the regurgitant usually recognizes that it may have a pleasant taste. And the process tends to stop when it's acidic. So the criteria for this syndrome has to be met for at least 3 months, with symptom onset at least 6 months before diagnosis. So now how do we differentiate the two common syndromes that we see? The motility disorder we call gastroparesis versus functional dyspepsia. The pathophysiology of these two may be different. Gastroparesis do tend to be either lined up as idiopathic or diabetic, and diabetes itself can cause a neuropathy where they have changes in the pacemaker cells in the stomach called the interstitial cells of Cajal. There may be changes in the macrophages, and most recently they have found some genetic mutations that can cause this. As far as gastroparesis, it is not diagnosed based on Rome-4, but it's based on the presence of typical symptoms of nausea, vomiting, postprandial pain, and weight loss, which often occurs with either testing that proves the stomach is delayed. That's gastric scintigraphy, wireless motility capsule, and breath testing. The symptoms duration really do not differentiate the two, and patients may have, again, delayed gastric emptying. PPIs do not usually help gastroparesis unless they have a lot of acid reflux, and tricyclic antidepressants may not be helpful for these patients. Functional dyspepsia, however, is a sensory and motor disorder, and these patients will have very similar symptoms to gastroparesis, but they're not necessarily having a lot of vomiting. They should not. Early satiation, postprandial distress, epigastric burning, and postprandial fullness is what's usually reported by these patients. And they may or may not have a delayed gastric emptying. So this is the difficult part, in that even patients with functional dyspepsia may have delayed gastric emptying. That's seen in about 1/3 of these patients. And proton pump inhibitors can help patients with functional dyspepsia. There are many disorders that masquerade as gastroparesis. So these are things like peptic ulcer disease, or what's called SMA syndrome, celiac artery compression, and other causes such as even eating disorders, which are very important for us to figure out and rule out. There's also central nervous system causes such as tumors that are, again, also important to rule out. And then there may be hormonal endocrine abnormalities with endometriosis or adrenal insufficiency that we should think about. There are many new diagnostic testing actually for gastroparesis that are exciting. So the old tests are x-rays, upper GI series, upper endoscopy, CT scan. Those are done really to rule out some kind of mechanical obstruction. We first have to rule out a mechanical obstruction before we call it a gastroparesis diagnosis. The three tests that are probably most often used: gastric emptying scintigraphy, which is the most common. That's a nuclear medicine study that's done by the radiology department. It's a 4-hour test, and it's important to be done over 4 hours because we are looking at the rate of gastric emptying at 2 hours, maybe sometimes 1 hour or even 30 minutes, and then definitely at 4 hours, and how much is retained. It's also important for the patient to regulate their blood sugar if they're diabetic before performing any of these tests, as a high blood sugar can affect the rate of emptying of the stomach. The wireless motility capsule is a capsule study that we do where we have patients swallow a capsule that goes through the entire gut, and it evaluates for both gastroparesis as well as slow transit constipation. Breath testing can also be done and is newly FDA approved. These are really nice, non-invasive, non-radioactive ways to really test patients' rate of gastric emptying. And then there's other tests that are really done only in motility centers, such as the antral duodenal manometry. For functional dyspepsia, we test what is called the gastric accommodation, where we see if the fundus, which is the top part of the stomach, can actually accommodate food. And the easiest bedside test for that is the nutrient drink test, where you have the patient drink Ensure or whatever drink they prefer and see how much of it they're able to eat before having symptoms. There's also electrogastrography, where we look at the actual tonic contractions in the stomach and see if they're too fast or too slow. And then there's other tests that we do for research only, such as balloon barostat. Now, the new exciting ways that are not validated yet are with SPECT, MRI, and ultrasound, and these are just not available, so we won't talk about them. Now, we've known for years that nausea, vomiting don't actually correlate very well with what we see on transit delay, both based on scintigraphy and even based on wireless motility capsule. And these are studies looking at 3 months follow-up, and then even 6 months follow-up was very similar. They can be the same for functional dyspepsia or chronic nausea, vomiting, as well as gastroparesis. These are the medications we use for gastroparesis. So they've been lumped into differences between what's called a pure prokinetic, what's a prokinetic, and antiemetic, which means it's used for both promoting peristalsis in the stomach and other regions, as well as helping with nausea. And then there's things that don't have any prokinetic effect, but somehow we have seen improvements in patients' symptoms. So the ones that are pure prokinetics, they're things like erythromycin, azithromycin. They're motilin agonists. These drugs will help promote gastric emptying, but they may not actually help with nausea. Prucalopride, Velocitrag are Velocitrax is not available, but prucalopride and tegasteride are available. These are only approved for patients with lower GI issues, not for gastroparesis or functional dyspepsia, but they're also prokinetics. And then there's old drugs, botanical, phytostigmine, and pyloric Botox injection to the pylorus. Those are really just pure prokinetics. The other prokinetic antiemetics, metoclopramide, is the only one that's FDA approved for treatment of gastroparesis, but it has a black box warning in that you can't use it for more than 3 months, and it can cause tardive dyskinesia. Then we have domperidone, which can only be obtained in Canada, Mexico, and the US by an IND, which is an investigational new drug agreement. And then we have ghrelin agonists. Relomorelin is the one being studied now in phase 3 trials for both idiopathics and gastroparesis. And then other new exciting drugs are also the new DT, D2, DT, D3 receptor antagonists, which don't prolong QT but act very similarly to domperidone. Then we have the ones with no prokinetic effect, tricyclics, mirtazapine, many antiemetics such as ondansetron, for example, and then gastric electrical stimulation. Now, we know that the most potent prokinetics are still azithromycin and erythromycin. They are fraught with prolonging the QT. We did a dose response curve to see what dose actually helps patients, and the dose of 50, 100, and 133 did pretty much the same. And these patients had complete improvement in their gastric emptying when it was looked at by gastric emptying scintigraphy. Now, does a delay in gastric emptying, though, predict how patients respond to the different medications? So this is why it is important to test these patients and see if they have delayed gastric emptying. Because the patients that have a delayed gastric emptying, they may do better on the pure prokinetics that we talked about. And the ones that don't have a delayed gastric emptying, they may actually benefit from the ones that are antiemetic and prokinetic. Because as we showed, some of the patients can have delayed gastric emptying, rapid gastric emptying, and then completely normal gastric emptying, and still have improvements when you look at them over 6 months. Now, it's also important to ask patients who have constipation and it's severe whether they have constipation. Because what we found, when the patient also has a delayed colonic transit, they actually do tend to get better in terms of their upper GI symptoms with constipation treatments, whereas the ones that don't have a delayed colonic transit, when we test it by wireless motility capsule, they just get better with prokinetics and neuromodulators, and constipation treatments don't really have an effect. Prucalopride has a prokinetic ability. It's a 5-HT4 agonist, and in doses of 2 milligrams versus placebo given over 4 weeks in this crossover study, in 34 patients who had both idiopathic and diabetic gastroparesis, there was an improvement in nausea and many of the symptoms that patients experienced. And this was statistically significant. Very few side effects were seen. The side effects were actually few patients who had headache and nausea, and then one patient actually had a small bowel volvulus, which is an obstruction. The great news is the neuromodulators that we use very often to treat patients for pain syndromes and also to treat cyclic vomiting syndrome and prevention do not delay gastric emptying. The safety of other drugs. So we're looking at relomorelin. This is the ghrelin agonist that was given to diabetics in this randomized placebo-controlled study. We saw that there's an improvement in their composite scores, in their nausea, fullness, abdominal pain, as well as bloating. So this is going to be an exciting new treatment that we can use for a lot of our patients. There are other drugs that affect centrally. They are great nausea drugs. This is aprepitant. This medication is an NK1 receptor antagonist. It prevents substance P from binding to NK1 receptors, as we talked about in the brain. And so it is great for chemo-induced nausea vomiting, but we use it for cyclic vomiting syndrome and also any kind of severe vomiting syndrome. In this study that looked at chronic nausea and gastroparesis, there was an improvement in the composite scores for patients, 46% improvement on aprepitant versus 40% that was seen on placebo, though, in terms of just looking at nausea. Rumination syndrome, I won't talk about. This is, really something that we'd send patients to psychologists for diaphragmatic breathing. And then this is just the kind of a composite of where and what the mechanism of action of these prokinetics are. And then the masqueraders. So SMA syndrome is a common diagnosis that patients come to me for, who have, symptoms of weight loss. They've had nausea, vomiting. It sounds very similar to gastroparesis. This is usually seen in a patient who's undergone a lot of weight loss. They may have malignancy as the cause. Trauma, scoliosis, for example, may cause this. And this is partial obstruction of the third part of the duodenum, and is due to a tight angle of the SMA off the aorta. Patients will have bilious vomiting. And in this diagram, this shows really how the celiac artery courses and the SMA. So this is the SMA here as it courses through from the aorta. And if patients lose their fat pad, there could be kind of less of a distance between these two. And so it's almost like the SMA crushes the duodenum that comes underneath it. And so these patients will have obstructive symptoms. This is how we diagnose them. Maybe we're lucky enough that we can see it on an upper GI series. Maybe we were suspicious when we did an endoscopy and we had a hard time going to the third part of the duodenum because it was compressed. And then CAT scan or ultrasound are really ways that we can do Dopplers and really see how the SMA is coming out of the aorta and whether the duodenum is getting crushed or stenosed underneath it. The management of this is usually decompression. We do an NG tube to suction. We may have to do tube feedings. Oftentimes, this is how I start management. I do the J tube feedings, bypassing that area and seeing if the patient gains weight and gets their abdominal fat pad back, if the symptoms will cease. The surgery is duodenojejunostomy that can be indicated in some of these patients that don't get well with J tube feedings. Now I'm going to go through a patient example that we often see. Do we have time, by the way? How much more time? I don't want to go.
If you go over, that's okay.
It's okay. Okay. So, for example, this is a patient case. We have a patient who has chronic nausea, abdominal pain. She says she vomits 4 times, or 2 times a day, but every day, and feels excessively full when she eats, has loss of appetite. The vomiting isn't always postprandial, but sometimes it can be. It's a little bit erratic. And she's already diagnosed with gastroparesis. On the office day, I usually will give them what's called the gastroparesis cardinal symptom index score, just to have a more objective measure of all of the symptoms of gastroparesis. Her score was 40 out of 45, which is high, extremely high. And her abdominal pain, she says, lasts about 30 to 45 minutes. Again, that's also not postprandial. In the past, she had a cholecystectomy because they did a test called the HIDA scan when they said your gallbladder emptying is slow, and they took the gallbladder out. Now she has this bile acid diarrhea, symptoms of bloating, pain that they called IBS, and then also complains of some fecal incontinence. In the social history, which is very important for us as gastroenterologists, whether it's a history of sexual abuse, physical abuse, any abuse, drug abuse history themselves, the patient divulges that they are dabbing, and there is a history of tobacco use. The studies that I reviewed, gastroparesis was diagnosed by gastric emptying scintigraphy. It showed 59% emptying only at 4 hours. Usually we look for 90% of the food to be emptied before we call it a normal study. And upper endoscopy showed that there was really not a lot of abnormalities with the stomach, but the doctor had decided to do Botox injection to the pylorus, and that actually led to an improvement for 30 days in this patient. But the patient continues to have vomiting despite the improvement. Colonoscopy was also done to rule out microscopic colitis. This was negative. Celiac was also ruled out. And then I actually had to look it up, what dabbing is. So I, looked up to see that dabbing is this thing that young people, I guess, do, and maybe older people, where they basically use butane hash oil to prepare this content of THC that's actually 60% more potent than normal smoking a pot. And perhaps some of these patients' symptoms could be related. There are definite reasons why patients may be doing this in places where it's legal or illegal. And some are doing it, obviously, for treating their nausea and vomiting symptoms. But this creates a huge issue with us, especially in states where this is not legalized, where it's hard to figure out if the symptoms are due to cannabis, if the symptoms are real gastroparesis, because THC can actually delay gastric emptying. And then what are we going to do with this patient as far as their treatment? Should we treat this patient like a cyclic vomiting syndrome patient? And what about narcotics? So this is an important difference between, cyclic vomiting syndrome. Cannabinoid-induced hyperemesis, definitely there's role of cannabis use in our patients that are doing this. THC acts on the cannabinoid receptor type 1, and it inhibits both peripheral and central initiated emesis through its actions. So it actually directly impacts the dorsal vagal complex because there is a distribution of these receptors on the vagus nerve. And so we have found that THC can also reduce gastric emptying when it's been tested in healthy volunteers. So that could be a cause, right? Much like we say opiates are a cause. And that the use of cannabis is actually much higher in cyclic vomiting syndrome. It's about 3. And it's also seen in patients who have functional vomiting. What we don't know though is a lot. So we don't know why some patients who use cannabis have vomiting. We also don't know what is causing this paradoxical reaction in some patients but not others. Is it genetics? Is it differential, like CB1 downregulation? Is it tolerance? Some people may need more and more with time. Is it an increasing potency with higher ratio of THC to cannabinoid or cannabidiol? And then is it longer duration of use only? In general, how much is too much is not well defined by Rome criteria. We usually say cannabis use based on the guidelines that cannabis use over 4 times a week for at least a year preceding onset of the cyclic vomiting is needed for us to call it cannabinoid-induced hyperemesis. How long to sustain sedation? We usually say a minimum of 4 weeks of abstinence, and then also to make a diagnosis, and the time it takes for the symptoms to go away may be a minimum of 3 of their typical cycles, or it could be 6 to 12 months. So as far as we can tell patients based on the recent guidelines that were published, this is the best we can tell them. Now, how about cyclic vomiting syndrome? Again, we need to identify triggers in these patients. It's very important, much like we treat migraine headaches. They need good sleep hygiene. A lot of times these patients are not sleeping well, and that's found to be true also in migraine patients. We need to make sure that they are not fasting for long periods. These are not patients that can do the intermittent fasting. Stress management is important. Hydration is very important. And then we divide patients into mild versus moderate and severe. The mild patients are the ones that get less than 4 episodes a year. They usually don't need hospitalizations, and you can use very effective drugs to abort these episodes. Those are ondansetron, phenothiazines, antihistamines such as Benadryl, and then you can also consider these vitamins and mitochondrial agents for treatment. For the moderate severes, that's more than 4 episodes a year. These durations usually last longer. It can last more than 2 days. They're hospitalized. They come to the emergency room oftentimes. And these patients really need more aggressive therapy. So they need good abortive therapy. These are triptans intranasally that we use in migraine headaches, ondansetron. Benzodiazepines can be effective, antihistamines, and then aprepitant, which we already talked about. Prophylaxis with tricyclics and topiramate has been found to be the most effective for this patient population, and then coenzyme Q10 and some anti-epileptics can also be used. This is what I give my patient. So depending on if they are that patient that is moderate to severe, I will give them a list that I want them to take to the emergency room with tests that I need them to get done. So the clinical assessment, vitals, hydration, lab testing is CBC. We want to see their BUN, creatinine. We want to check the liver enzymes, make sure on lipase level they don't have pancreatitis, and then check their electrolytes and fix them if they are abnormal. An EKG should be done in these patients, urinalysis, and then any imaging as determined by the emergency room doctor. So treatments are outlined as giving them fluids, so hydrating them. For vomiting, nausea, ondansetron is very effective, and it's just basically given, administered at high levels, and then continued. Diphenhydramine, which is Benadryl, is also considered. For sedating them, you can give them things like diphenhydramine as well as lorazepam. And then for the migraine type symptom, you can do sumatriptan, and I have the dosages on this slide. For pain, my most favorite is probably NSAIDs, which is ketorolac. The patient can get in the ER. If the patient needs to get narcotic, I am not resistant and against that for these type of patient population. However, if ketorolac works and it tends to work well, we usually avoid opiates. Reassessing these patients is important, finding out why did the treatment fail, what's the positive treatment response upon discharge. You do need to give them medications to kind of help wean them down from this, but usually most patients can go off the medication in a few days. And for sedation, again, we use lorazepam or diphenhydramine. This is a great study that I really love because it uses electroacupuncture in diabetic patients to improve their nausea. In this study, they had 11 patients with diabetic gastroparesis. Their mean age was about 50, and they gave this visual stimulus that caused nausea, and then they did acupuncture and noticed that the nausea and score actually decreased when they used the electroacupuncture. And usually the regions that acupuncture is done is ST36 and PC6. And our only issue is the availability, right? So we need to find a good acupuncturist that sees our patients who have these nausea vomiting syndrome. So it could be very effective. What I don't like is opiates, right? So I did talk about cyclic vomiting, but that's one condition. It is okay to intermittently give patients opiates. But in general, opiates fail. They worsen nausea, vomiting scores. They worsen patients' quality of life, whether they have functional dyspepsia or gastroparesis, and these studies show that. Last of two slides. So what we do also is G-POEM. So that's something that is being offered by many advanced endoscopists and folks who do this surgery, which is very similar to POEM that's done for achalasia patients. The advanced endoscopist or the surgeon goes in, and what they do is they do a myotomy of the pyloric muscle. And there hasn't been any sham trials in this, but there are patients that may have a focused pyloric abnormality. These are patients that have pyloric stenosis, whether it's caused by, acquired, or maybe they have diabetes or other etiologies. And in these patients, when they cut that muscle, the pylorus, which is the same one we Botox, they have found in studies that the GCSI score and quality of life can improve up to 6 months. In this study, they actually looked at the patients up to 18 months, but there were only 7 patients left in the study up to 18 months. So we really do need long-term, validated, randomized controlled sham trials to be able to really see if this is going to be effective. There was a decrease in hospitalizations, though, and use of healthcare resources in the patients that received G-POEM. So this is my last slide, and I like to this is how a gastroenterologist thinks of how to work up these patients. So if I see a patient that has some kind of gastric impairment and I think of their pathophysiology, everyone has a different cause. So in some patients, the cause of gastroparesis could be that they have Ehlers-Danlos syndrome or some kind of connective tissue disease, scleroderma, lupus. It could be that they have Parkinson's disease or cystic fibrosis. So for those, the pathophysiology is really different than what we see with the diabetic population. And it's totally different than what may see with the idiopathic population, which a lot of those patients tend to be post some kind of viral syndrome. So we use the tools that we have to differentiate patients into what is their gastric impairment. So if it is a decreased driving force, if they have the slow waves or the interstitial cells of Cajal in the stomach may be impaired, we can use EGG and test that. We can also perhaps one day do MRI, PET scans. You can easily do the nutrient drink test in patients who have postprandial pain and nausea and see if they really may be functional dyspepsia. If they are functional dyspepsia, usually we try PPIs first. We do dietary management. We tell them to do small, frequent meals. Maybe things like tricyclics, bispirone may be effective. And maybe some of these patients need those combined antiemetic prokinetic combos, such as domperidone and others. And in some, gastric stimulation can be helpful. If you have a patient who has this pylorospasm, poor distensibility of the pylorus, we can actually measure that now using this technology called EndoFlip. We can also see that on perhaps angioduodenomanometry if the center has it, wireless motility capsule. And if that's the cause, usually we'll try doing pyloric Botox injection. And if the patient responds to 200 international units getting injected in the pylorus by endoscopy, then perhaps G-POEM may be an indication for that patient. In the patients where the whole antrum and the body of the stomach doesn't work, these are patients with complete paralysis of the stomach. They may be diabetic. Again, they may have a connective tissue disorder. These are patients that things like scintigraphy, wireless motility capsule, and the breath test that we now have, the GBT, may be very effective in really figuring out the delay, the degree of delay. And depending on the degree, sometimes you can manage them with just a low fiber, low residue diet. Other times you may have to use the pure prokinetics and antiemetics, and then gastric electrical stimulation has been helpful. All right, very good. So I will reserve the questions to the end, actually, and thank you for your attention. Transition here?
Sure. Right, click right
Oh,
here.
click there.
Now click transition.
Ah, okay.
All right.
And now Dr. Tacker is going to take over for behavioral medicine interventions and IBS.
Thank you so much. Thank you so much. So today I'm going to be talking about behavioral medicine interventions and referral options for patients with irritable bowel syndrome. I have no disclosures. So in this talk, I'll describe how behavioral factors may influence IBS. I'll review behavioral medicine interventions for IBS, and I'll discuss behavioral medicine referral options for patients with IBS. So to start off, what is irritable bowel syndrome? IBS is a significant public health problem. It impacts 14% of adults in the United States. And IBS symptoms include abdominal pain associated with altered gut motility, including diarrhea and/or constipation, or a mixture of the two. However, patients often also report other symptoms such as bloating, fatigue, nausea, and urgency. And IBS is currently conceptualized as a disorder of the brain-gut interaction, meaning that the communication between the brain, gut, and central nervous system is dysregulated, which causes the bowel to become overly sensitive to stimuli that other healthy individuals may not experience as painful. So why is psychological treatment important in the management of IBS? Well, we know that IBS is influenced by behavioral factors. We know that psychiatric distress is often elevated among IBS patients, and IBS itself is a stressor. IBS is a chronic condition, and conventional medical and dietary interventions provide inadequate relief. In fact, there's no single medication that can alleviate all IBS symptoms. We also know that behavioral treatments are best suited for patients with more severe GI symptoms because these are the patients who often do not respond well to medications. It's also important to note that we currently conceptualize IBS from a biopsychosocial framework, meaning that biological, psychological, and social factors can all influence the development of it. We also know that psychosocial processes can modify the brain-gut interaction, which can help explain why psychological therapy can be a useful treatment for people with IBS. So what makes psychological treatment an optimal supportive therapy for patients with IBS? Well, alongside conventional medical and dietary interventions, we know that psychotherapy has a lot of great benefit. We also have evidence that antidepressants may be used in the treatment of IBS, and psychotherapy and antidepressants have similar effects. There's also been research to show that gut-directed hypnosis, a type of behavioral treatment, works just as well as the low FODMAP diet, which is a common dietary intervention for this patient population, for reducing GI symptoms. But it's even better than diet when considering psychological factors. Perhaps the most notable reason is that decades of research suggest that behavioral interventions improve IBS symptoms, emotional well-being, and quality of life among patients with IBS. So, what are the evidence-based psychological interventions for this patient population? Cognitive behavioral therapy, relaxation therapy, multi-component psychological therapy, hypnotherapy, and dynamic therapy have all been shown to be more effective than control therapy, with number needed to treat between 4 and 6. Other treatments, such as multi-component psychological therapy delivered via telephone, contingency management, and emotional awareness and expression training, have been shown to appear to be beneficial, but there's only been one randomized controlled trial for each of these. That being said, most clinicians use cognitive and behavioral therapy and gut-directed hypnosis in clinical practice, so that's what I'm going to focus on today. So what is cognitive and behavioral therapy for IBS? Because when I talk about CBT for IBS, people think it's all great and all of that, but they have no idea what it actually is. So that's what I'm going to explain now. The theory of CBT is that maladaptive thoughts trigger psychological symptoms and physical tension, which can trigger or exacerbate IBS symptoms. So I want to emphasize that CBT for IBS targets IBS symptoms specifically, not necessarily addressing related anxiety or depressive symptoms and things like that. Those can be addressed through behavioral interventions as well, but by providers who specialize in that area. CBT is generally brief, focused on the present, and involves skill building to help patients deal with stressors or GI symptoms more effectively. When we introduce CBT in clinical practice, we talk about the motivation that patients have for treatment and their goals are identified because it's really important that we have to be on the same page. Treatment itself involves psychoeducation, cognitive, and behavioral components, which I'll talk about in the next slide. So I titled this slide CBT for IBS Demystified because, again, people oftentimes have no idea what CBT for IBS actually means. So I'm going to describe some of the components in more depth to give you a better framework. And note that all of these components are not used for every single patient. It depends on their needs and circumstances. But the first component on the left, psychoeducation, is almost always a part of psychotherapy because it helps patients develop insight into what might be influencing their symptoms and gives them a better understanding that they might be able to control factors such as responses to stress and arousal that may be contributing to their IBS. The next component, self-monitoring, is sometimes used to help patients build awareness about triggers and things that might impact bowel symptoms, such as daily hassles, attitudes, and activities, and things like that. This helps patients change by helping them to get a handle on what might be controlled and giving them a baseline in which they can evaluate their progress. It also helps to keep them motivated and helps them identify that they can learn new skills for coping. However, it's important to note that this might be less helpful for patients who are highly focused on their symptoms. It might be triggering for those patients. Next, relaxation training helps people learn how to reduce arousal and stress and gives them a better sense of control. There are several relaxation strategies, and some examples might just be diaphragmatic breathing, progressive muscle relaxation, and guided imagery. Cognitive restructuring is another skill that's used, which is aimed at reducing symptom-related anxiety and hypervigilance. The focus of cognitive restructuring is on reducing negative thinking patterns and worry related to symptoms. Patients may be asked to track their thoughts, and they're coached in learning new, more adaptive ways of thinking. Problem solving helps patients more flexibly address their problems. Patients are taught active problem-solving strategies for controllable issues and emotion-focused strategies for uncontrollable problems. Examples might include reframing, reinterpreting the meaning of a situation, getting support from others, doing relaxation strategies, engaging in acceptance, and letting go. And next, exposure to feared situations helps to minimize avoidance and safety behaviors. Another important component is addressing health behaviors such as exercise, routine, and sleep, or referring to a dietitian to address dietary needs. All of these can help promote healthy lifestyle habits. Another useful behavioral strategy for patients with IBS is gut-directed hypnosis. Hypnosis targets stress and gut sensitivity by inducing a state of deep relaxation and focused attention that allows people to become more receptive to suggestion, which in turn facilitates healthy changes in their mind and body. So it's a verbal intervention that involves a script. The patient initially receives hypnosis in session, and then they're taught how to engage with hypnotic techniques on their own to manage their IBS symptoms long term. And patients really enjoy this particular intervention because it's been demonstrated to have great impact, but there's also been a study in my next slide which looked at this very question. How do people view hypnosis as a clinical intervention? And in a national population-based survey in the US, most people reported a positive or neutral view of hypnosis, and half were willing to consider seeking hypnosis treatment, and most reported hypnosis as a useful intervention. So the bottom line is that people really like it, and I think it's great to introduce a treatment that can target IBS symptoms specifically that may be something that they can't get through other avenues of care. So that begs the question, what's happening with IBS treatment in the real world? This, as you can see here, I'm afraid that your irritable bowel syndrome has progressed. You now have furious and vindictive bowel syndrome. Well, we certainly hope not. We hope that we're actually reducing GI symptom severity and helping patients engage in a better quality of life. In a recent systematic review, we found that psychological treatment for IBS delivered in GI clinic settings can reduce IBS and psychological symptoms and improve their quality of life. So there are some positive benefits. However, the real question is, how often are patients with IBS referred to behavioral medicine services? How often are they getting the care that they need? And the answer, unfortunately, is not as much as we'd like. In an HMO setting in Seattle, only 10% of patients with IBS were offered a referral to a mental health provider by gastroenterologists, and only 9% by primary care physicians. Unfortunately, referral rates from other integrated care settings, such as the VA and non-VA academic medical centers, are unreported. So, to help move forward and change all of this, I recently worked with a team of colleagues to develop a referral toolkit for gastroenterology providers to identify the best candidates for behavioral medicine services and provide guidance for the referral process. This was funded by the South Central MyRic, and you can download it for free at the link here. So if that's something that you're interested in, you should definitely go ahead and download it and use it in your practice, or if you're a patient, it provides great information for you moving forward. It was also funded by Baylor College of Medicine. So the first aim of this study to develop this referral toolkit was to better understand stakeholder perceptions of barriers to the adoption and implementation of behavioral treatments for patients with IBS in both VA and non-VA GI clinics. So we conducted a qualitative formative evaluation using in-depth interviews with patients and providers. We also asked clinical leaders to give their perspectives regarding the importance, feasibility, and acceptability of behavioral medicine and the toolkit approach. Through these interviews, we looked at the attitudes of these individuals towards behavioral medicine. We looked at who is appropriate for treatment. We looked at the attitudes towards referral processes. We also considered how patients and providers can communicate about IBS symptoms and treatment. And we considered barriers and facilitators to treatment attendance. The second aim of this project was actually to develop the toolkit. So we used rapid qualitative analysis to identify preliminary themes which informed the development of the referral toolkit. And feedback obtained from patients, providers, and clinical leaders guided modifications to toolkit materials. So our sample included 5 GI providers and mid-level, which included gastroenterologists and mid-level providers from the VA, and 9 behavioral medicine providers, including psychologists and psychiatrists from the VA. On the non-VA side, we had 9 GI providers from that end, and behavioral medicine providers were an N of 3. So the barriers that we found from a patient's perspective included stigma about mental health, having the provider think that it's all in their head, the patient wanting a medical fix, work and school conflicts, lack of motivation or willingness, lack of insight or openness, or transportation or travel distance issues. Medical provider side, a lack of knowledge, for example, how to refer, best treatment options, how to make an informed consult, were the main barriers. And from a system level perspective, scheduling issues, time in clinic, and limited resources were the main issues that we found there. So this here just gives you an example of the actual referral toolkit, what it looks like, and the flow. And I'm going to go through each step that we suggest in the next slides. So the first step here begs the question, is the patient a good candidate for behavioral medicine? And so it's important for providers to understand this so that they can identify the best patients to refer to behavioral medicine. So as you can see here, hopefully it's clear on the screen, is that patients who have moderate to severe IBS symptoms, including pain, that have not responded to first-line medical or dietary interventions are good candidates. Patients who have stress factors, psychosocial factors, or emotional factors that trigger or exacerbate their IBS symptoms, or they perceive their IBS to be a stressor, are good candidates. So a provider might ask the question, do you believe stress impacts your IBS? Do you believe anxiety or depression impacts your IBS? Is IBS a source of stress for you? Or does IBS interfere with your quality of life? Patients who are motivated to participate in treatment or prefer a non-drug approach are also good candidates. Provider again might ask the question, how motivated are you to learn new ways to control or reduce your IBS symptoms at this time? And then this is a really important point that I believe, is that a patient believes that he or she can have control or learn ways to control his or her IBS symptoms and their impact. So a provider might ask the question when they're meeting with the patient, do you believe that there are things that you can do to improve your IBS symptoms? Now, on the other end, a patient who's a poor candidate would be one who had an unstable medical condition that needs immediate attention, those with unstable psychiatric comorbidities, like anxiety and depression that's untreated or unrelated to their IBS, or current severe psychiatric symptoms, like acute suicidal ideation, for example, or psychotic symptoms, OCD, or an active eating disorder. All of those patients should be seen by a specialist who can address those issues. Also, patients who are uninterested or refuse to engage in behavioral medicine treatment, they're not going to be good candidates because they're not going to be motivated to engage in care. And there's some ideas for how to handle those patients, as you can see below. We also have some information about screening tools that may be useful for providers to use if they have the time. And all of that is in the toolkit. I don't have time to go into it now, but you can take a look at that on your own. So the second step here is it's important to educate patients about behavioral medicine treatment. The first point, IBS is known to be worsened by psychosocial factors, which we talked a lot about in the beginning of this presentation. And the second point is educating the patient about the brain-gut connection, the stress-IBS link is really important. You might say something such as stress impacts the functioning of your gut. Some patients are gut responders to stress. It doesn't mean that symptoms are all in your head, but that they may be related to the connection between the brain and the gut. And hopefully that will give a patient a sense of why you might be doing the referral. The next point is validating that IBS is real. You might say something such as, IBS is a medical diagnosis, and the pain and bowel problems associated with IBS are real, even if no medical cause can be found. It's also important to describe the treatment options so that you and the patient are deciding together about what is best for the patient's care, and of course sharing the evidence so they know what kinds of treatments they might be getting into. The next step is to explore the patient's preferences. First, it's important to identify patients' treatment goals and preferences on that end and identify if you have mutually agreed upon a treatment plan. It's also important to empower the patient by saying something such as, it's easy to feel lost when dealing with multiple providers, prescriptions, and approaches to IBS care, but how you proceed with your treatment, it's in your hands. The good news is that you can develop new ways to manage your IBS and gain better control over your symptoms with strategies we talked about today. Also, offer the option of behavioral medicine services and identify if the patient's interested. If you're unsure about whether or not the patient is interested, you could ask open-ended questions. For example, you might say, tell me more about the difficulty you have when your IBS symptoms are triggered when you're out to eat at a restaurant. Or empathize with the patient, use reflective listening, summarize the patient's statements, and also build their self-efficacy. Saying things like, how confident are you that you could get better? If the patient says no, or you could say something like, this is the perfect place to start, building your confidence to manage your IBS now. Ultimately, it's the patient's decision, so you don't want to push them into doing something that they're not ready for or they're not open to. The next point is to initiate the actual referral. And this really depends on the healthcare system that you're in, because we know that there are various different types of providers in various different types of places, and there's not always a GI psychologist on board. However, there might be a health psychologist in the area or a GI psychologist that you're not aware of in the area, so it's important to identify where you can send the patients for appropriate care. And so here there are some resources, including the GastroPsych directory, which I'll highlight because that is probably the best resource we have to date of all the GI psychologists who are practicing in the country currently. Next, it's important to engage the patient. So perhaps providing them information about how to schedule an appointment with a behavioral medicine provider and answer all of their questions and concerns. You can see here an example of a pamphlet that may answer many of the questions that the patients have. Or if the patient's not interested in formal behavioral medicine treatment, there are resources for self-management, and that's on the next couple of slides in which you can give them so that they can engage in some behavioral medicine care on their own. And the next slide has patient information that you could actually use in your clinical practice to help patients understand their IBS more effectively. Or if you're a patient, this might provide more information to you about how behavioral factors might be influencing your IBS and your care moving forward. So feel free to download this so that you can use this as a resource for yourself moving forward. I don't really have time to go through all of the details of it, but it could be a great resource for patients in practice. On the next slide here, we have several websites that you could go to that have resources for patients or providers who are providing behavioral medicine care, or gastroenterologists who might want to work with providers who are providing behavioral medicine care to give to patients about this type of treatment. And most of these are listed in the referral toolkit itself. However, I'll highlight that the Rome GI Psych section, which is rather new, is not in the toolkit, so you might consider looking at that in addition to the other resources that are listed here. I've also listed some books, including Controlling IBS the Drug-Free Way, a 10-step plan for symptom relief by Jeff Lackner, which is a great self-help resource for patients, as well as The Mind-Gut Connection by Dr. Emran Meyer, which is a great resource which includes a lot of great information for people to learn more about the condition. And I don't have step 6 on as a slide. However, it's important to monitor progress. So that is the last step that we identify in the referral toolkit. So we have to identify if the patient was actually scheduled and attended a behavioral medicine session. We have to coordinate care with both the GI and the behavioral medicine provider. And if you're a patient, then also taking an active role in coordinating that care is very important for yourself. Also important to know if the patient's IBS symptoms, stress levels, and quality of life have shifted after care. So assessing that along the way can be very useful, and considering patients' medical management to determine if alterations are needed following behavioral therapy. So I want to thank the following individuals for their participation in the development of the referral toolkit, and also the patients and providers who gave their input and support on this project. So thank you for your time today, and we greatly appreciate you tuning in and listening to our talks and topics today. We'll open up the board for questions.
Hey, so we're going to go ahead and start taking some questions. I think the first question is for Dr. Moshiri. First one is, in patients who have undergone gastrectomy as a treatment, what is the next line when tube fade fails and TPN dependent post-op?
Oh, great question. So hopefully the gastrectomy is not done before the tube feedings have been tried. Those are really rare cases where that's required, I think. I can just note in the past 15 years of my experience, probably I've had a couple of patients that have had total gastrectomies. So I would say, if tube feedings really have been tried and using some of the more tolerable substances that patients are not allergic to, and it's been given via a pump that's been slow infusion, then TPN is really the only other option. And there are places that will do whole gut visceral, like multi-visceral transplantation. I have had patients that I send for that. The mortality of that 5 years out is actually improving, but it's not great. And so I think, that is going to be an option in the future. And hopefully the rates of mortality and morbidity will improve. But I think at this time, really what we have is TPN, and hoping that patients will just, get better. The other things that I've done in my past have been for patients that are idiopathic and have been found to have some kind of enterovirus infection that started their disease process. Those patients can have IVIG. And, this tends to also be patients who have dysautonomia. And IVIG, you really have to work with the closely with an immunologist to see if this can be administered on a monthly basis. Some of those patients, I have had some success getting them off TPN, but it is really a difficult scenario for us as gastroenterologists as well, even as motility experts.
So the next question is for Dr. Talker. The question is, are there resources in the South Florida area for hypnosis?
I'm not sure of that offhand, but definitely check the GI Psych directory, as well as there's a hypnosis website from Dr. Oliver Paulson, which has many providers who provide the service. And I have that in my referral toolkit, so you might check there as well for those particular providers.
Was it ibshypnosis.com?
Yes.
Mm-hmm. I get it.
Yeah.
It's you want to say it? Say it.
ibshypnosis.com.
Yeah.
Yes.
All right. So the next question is for Dr. Moshiri. In these studies, were there any patients determined to have symptoms of surgical adhesions?
Most of the studies that I talked about, they actually exclude adhesions because that would be a cause of perhaps an obstruction. Endometriosis tends to kind of hide, and that is one of those things that when we do imaging, even if it's CT enterography or MRI enterography, which is much more better for soft tissues, for example, in the case of MRI, we can actually miss adhesions, and so they are usually excluded in most of these studies. And so I would say no.
Okay. Next one again is for you. After a vertical sleeve gastrectomy and the empty study looks normal, what can be done to help if there are still vomiting, pain, and intense nausea?
So a lot of the patients that undergo vertical like sleeve gastrectomy, the the reason for their nausea or vomiting may be that they basically have a smaller right stomach. They cannot accommodate as well, so they tend to have actually rapid transit rather than slow transit, and the vomiting could actually be more related to them having reflux of contents because they have a smaller stomach and because the gastric actual procedure can cause some esophageal dysmotility. And so a lot of times it's really important for those patients that are undergoing sleeve gastrectomy to have some kind of motility testing, preferably I would say esophageal manometry and pH testing to make sure that they don't have acid reflux or some kind of other bile reflux, via impedance pH testing before they undergo vertical gastrectomy. Now, if it's already obviously been performed, then I do use prokinetics. Usually, an upper GI series will show if the stomach is where the residual contents are retained, or whether it is really this reflux situation. And if it is acid reflux, I do use medicines like domperidone. Usually, I stay away from metoclopramide just because the symptoms outlast 3 months, and the FDA warnings are at 3 months. So that can be very difficult, and perhaps other prokinetics.
One other question is there a book that explains the brain-gut connections so that they may help others so they can understand when they're advised to see a therapist?
I think one of the best books that discusses the brain gut connection is the one I presented by Emran Meyer, the Mind Gut Connection. And to better understand when they should see a therapist, I think that really depends on what their needs are and circumstances are, and whether or not they feel with their GI provider that it's an appropriate treatment next step. So it's definitely something to talk to your gastroenterologist about and see if it's the right option for you.
All right. I'm just going to wait a few minutes to see if any other questions come in. But if not within the next minute or two, if there are not any additional questions, we'll go ahead and close out the Facebook Live today. I really want to thank everyone for coming in and participating and all the good questions. And I do not see any new questions coming in, so we're going to go ahead and call it for today. So thank you, Dr. Moshiri and Dr. Talker, for being able to come in with us today. And I hope everybody over there on Facebook has a great day.